Our next session is going to be a presentation from the Vanderbilt Center. Excuse me. We do have one virtual speaker. So Digna Velez Edwards will be presenting Project 1, AIM 1 virtually. Then we're going to have AIM 2 presented by Drs. Megan Shuey and Sudeep Santankar, Project 2 by Andrew Weesey, and then the Phenotyping Core by Wei-Chi Wei. And then I will conclude with the Admin Core and the Precision Therapeutics Academy. So, all right. So our first speaker is Dr. Velez Edwards. Digna, you can go ahead and get started.
Sure. Can you hear me?
Yes, we can. Perfect. Thank you.
Okay, great. So I'm Digna Velez Edwards. I'm a professor and vice chair of research at Vanderbilt in the Department of Obstetrics and Gynecology, and I am the lead for Project 1, and I'm going to be going over Project 1, AIM 1. Megan Shuey will be taking over and going over Project 1, AIM 2. And so Project 1, AIM 1 assesses the knowledge and attitudes regarding PGX testing among pediatric and pregnant populations. Go ahead, advance. Okay. And so before I get started on the progress of this AIM, I'm going to reorient everyone on why we are doing this project to begin with and our motivation for this project. So PGX testing is becoming more accessible. So PGX testing guiding drug prescribing has become more accessible with over 200 drugs with PGX information in FDA label and 75 designated by CPIC as clinically actionable. Studies on how PGX testing can guide medication or dose selection often excluded in pediatric and pregnant populations. PGX studies in pediatric and pregnant populations are crucial for establishing best practices in the use of PGX testing in these groups. There's physiological differences across pregnant and pediatric populations in comparison to the general adult populations. So pediatric and pregnant populations require intentional clinical and physiological considerations. This is in part due to dynamics in gene expression and pharmacogenetics that are unique to pregnancy and childhood that make extrapolating PGX-based clinical guidance established in adult populations to pregnant individuals and children inappropriate. In addition, it's possible that clinical guidance based on metabolizer status may make extrapolating that information different in pregnancy. Furthermore, there may be additional barriers that prevent participation in research by these populations. For example, ethical considerations regarding understanding of genetic testing, consent for genetic testing in pediatric populations, and understanding of PGX testing may create barriers, and understanding perceptions of PGX testing and use in clinical care in pediatric and pregnant populations may be helpful for promoting studies regarding PGX testing in these groups. And so all of these factors motivated us to proceed with our study where we wanted to assess the knowledge and attitudes regarding PGX testing by conducting a survey-based clinical trial in these two populations. And so for Project AIM 1, we conducted a clinical trial where we recruited a population of pregnant women or pregnant individuals, pregnant people, and a pediatric population of children with chronic conditions, so 250 in each group. We conducted a survey, a baseline survey assessing their knowledge and attitudes regarding pharmacogenetic testing. This included information regarding their attitudes regarding pharmacogenetic testing, their interactions with the healthcare system, their history of medication use, as well as several other survey items. We provided PGX testing in the clinical setting. At Vanderbilt, we're able to provide PGX testing in the form of a panel that's actually put in their healthcare record And so this was returned to them in the electronic health record at Vanderbilt, along with instructions on their metabolizer status that was returned to their doctor. We then randomized them into two groups. One was provided with a supplemental educational video that provided them with additional information regarding interpreting their results. And then a follow-up survey was done that assessed their knowledge and attitudes again in order to assess if their attitudes changed by getting the PGX testing and by getting the educational video. Because we wanted to test whether that changed by this act of getting PGX testing and the educational video. As part of our design, we also included conducting a community engagement studio that we conducted prior to doing our clinical trial. This was part of our study design. So we did this prior to submitting our IRB. So when we were putting together a study, we convened two focus groups. One was a group of pregnant individuals. One was a group of parents with kids with chronic conditions. And so these community engagement studios, they have at Vanderbilt, you're allowed to submit a request for a community engagement studio for any study that you're putting together really at Vanderbilt. So we convene a community engagement studio in order to get feedback on our study materials, our survey, our fact sheets, our study design from participants that we were targeting for recruitment. And we updated our material accordingly. But I sought recommendations on our recruitment strategy, our survey materials, and then we updated according to that. We published our tutorial on our community engagement studio back in 2022. And it was actually very useful. So here's just kind of a couple of snapshots, some feedback we got. But they gave us a lot of information that, we really wouldn't have gotten on our own. And if you've never done a community engagement studio or just gotten community feedback from a focus group, I'd recommend getting one. But like one participant told us, I have a child with multiple conditions, and getting this kind of information regarding pharmacogenetic testing is really valuable and meaningful and would really reduce stress in my life. While another participant had concerns about insurance costs and coverage. And, it's really surprising the kinds of concerns that participants have. And so we did this before we implemented our study as part of our study design. And then this day and time as part of our update here, we've completed recruitment of both arms of the study. For our maternal arm, we had to oversample. And so we have baseline data completed for 439 participants, but we have now PGX testing results for 260 participants. Our target was 250, as you recall. We oversampled and got 371 with baseline data complete for our pediatric arm and have 250 PGX testing results. Our progress to date, these are our goals, and these are what we have completed to date. We have our community engagement studio. We have our deliverable of our published paper. We completed recruitment of the maternal arm. We have published our protocol and a summary of our baseline characteristics and an analysis of our survey data that was published in Pharmacogenomics. And that describes our maternal and pediatric population. We've analyzed our survey data in association with demographic characteristics for our maternal arm of the study. That's been drafted, and we're getting ready to submit that to JAMA Network Open. We've analyzed our pre and post survey data for our video arm. That manuscript has been drafted, and we're getting ready to submit that. We've completed recruitment of our pediatric arm. That was included in our protocol manuscript describing the recruitment strategy and the baseline characteristics for that population. And we're in the middle of analysis of our pediatric data currently. And here's a brief summary of some of the findings from the maternal analysis. This is a summary of the characteristics of the maternal population we recruited. The maternal data, this population, they were age 18 to 46, a mean age of 30. 40% were enrolled between 12 to 15 weeks gestation. 70% are married or living as married. 81% reported being good or very good health. Over 2/3 of the individuals are currently taking at least one medication regularly. And there was a large variation in income and education levels. And most reported having existing health conditions, with behavioral health or mental health conditions being the most reported. With regards to their familiarity with the terminology, and so this plot has terms that we surveyed them with. So we surveyed them with regards to their familiarity with common terminology related to genomics. So things ranging from, how familiar are you with terms like DNA, heredity, gene, to more complicated terms like genomics, pharmacogenetics, metabolizer status. And we scored them on a Likert scale, which we have color-coded here on this plot. And then we also, we summarized that here, but then we also tested whether these associated with some of their characteristics, like their age or their income status or other demographic characteristics. And so what we observed is terms covered in high school and middle school biology class, like DNA, chromosome, gene, heredity, were more familiar to most participants. The majority of participants, not all or only slightly familiar with specialized terms like metabolizer status or pharmacogenetics and precision medicine. Individuals with higher levels of education had higher levels of familiarity with scientific terms, including terms like genomics and PGX, and increased age associated with reduced familiarity with some terms. With regards to their attitudes about PGX testing, overall, the participants thought PGX testing was very useful for their doctors in selecting a treatment, as well as doses and decreasing side effects for medications. But they didn't all agree about it being done routinely. As you can see, PGX testing should be done routinely as a question. The majority said they neither disagree or agree as far as their response. With regards to opinions on their healthcare providers and PGX testing, individuals with worse perceived relationships with their providers were more likely to state they were uncomfortable with their provider recommending, accessing, and sharing their PGX testing results, were more likely to have lower levels of confidence in their provider's understanding of the PGX results, and were less likely to express agreement that PGX testing could help their provider decide on medications in dosage. So the relationship with your provider really seemed to determine how they responded to the questions regarding the utility of the testing. We also analyzed whether just receiving PGX testing improved your overall knowledge of terminology and other questions we asked. And what we saw was if you just received genetic testing, you seem to understand what genetics was providing and the terminology better. So what you see here is pre and post results regarding their understanding of metabolizer status, pharmacogenetics, and precision medicine terminology, and the significance of those tests. And so their understanding of those terms improved significantly. Their understanding of basic terminology didn't improve because they reported understanding those terms at baseline. We also did, these are called Sankey plots, which are done for pre-post testing for the video arms of the clinical trial analysis. And so we tested whether the baseline results changed after conducting our PGX testing and our educational videos in the follow-up testing. And what we saw was that their responses significantly improved in follow-up analyses, or in follow-up responses for their surveys for their familiarity with terminology with p-values of 8 times 10 to the minus 8. So the videos significantly improved their understanding of terminology. And this is just one snapshot of one of the results. It also improved for several of the other categories that we analyzed. So providing an educational video seems to significantly improved understanding of several of the categories we analyzed. And in conclusion, pregnant individuals had favorable perspectives on PGX testing, but their characteristics impact their knowledge and attitudes. Patients' relationships with their providers was a major determinant of their perceptions of PGX utility. Receiving PGX tests also impacted whether they believe genes contributed to medication responses, understanding of how PGX could be used in healthcare, level of agreement of PGX results being useful for improving their and their family's health, and the level of agreement that PGX testing would lessen the likelihood of their experienced, if they experience a side effect. And the educational video had further effect, especially on terminology. And with that, I'll pass it on to Megan, who will be going over our PGX analysis.
All right.